Welcome to Health Signals, episode 4, the podcast where insiders in healthcare help you understand whether or not what you see in the news is a signal or a trend in healthcare and beyond. I'm joined by my co host, Catherine Smart, former president of the Canadian Medical Association and one of Canada's 100 most powerful women. I'm Alika LaFontaine, another former president of the Canadian Medical Association and a top Maclean's healthcare innovator. Been a long summer. How you been?
I've been fantastic, Alika. How about you?
I've been good. We've been doing a lot of traveling across the country. I think this summer was rebound visits to family.
Yeah.
During the pandemic, didn't really travel much of anywhere, but went down and visited pretty much every family member who's in Canada right now. So kids are happy to be back to school next week, and it would be tough to actually pull them on another trip, I think. How about
Yeah.
yourself?
Yeah, I hear you. Same thing. I just was visiting my parents and my kids are still there, hanging out with them this week. And yeah, we did lots of little trips and excursion places. I took my son on a river rafting trip down in Idaho on the Middle Fork of the Salmon, which is one of America's great rivers. And that was a really very cool experience.
Lots going on in healthcare right now. What types of things are front of mind based on what you've been reading and experiencing in healthcare?
Yeah, I think what's top of mind for me is just how much of these same issues are raising their heads without really any improvement that we're seeing. We're having ongoing overcrowding in emergency departments, massive inpatient boarding in emergency departments, emergency department closures, access to care issues, severe burnout reported from physicians and across the healthcare system from all the wonderful other professionals we work with as well. And I think what's concerning is I don't think we've really seen a whole lot of solutions. One positive I would say has been with the new payment model in BC, we've seen a lot more attachment of people to longitudinal primary care and more physicians coming back to that. So that's maybe a good news story a little bit about how when you start, listening to what physicians are saying in terms of what they need to make office-based practice sustainable, you can see some change. But I think broadly in the system, we're seeing a lot of the same challenges, and it's really worrisome. What do you
Mhm.
think?
It almost seems like people are going back to a playbook that we know doesn't really work in healthcare. There are obviously pockets of hope where things seem to be moving forward. BC's payment model, any province that's adopted a payment model for primary care that moves away from fee for service to
Yeah,
instead compensating you for your time or compensating you for the number of patients that you see in their complexity, it does tend to be better received, I think, by primary care physicians, especially folks who want to move away from that churn of getting people through the door as fast as possible to really treating what needs to get
yeah,
treated. So I think that's something that we know is more likely to work than less likely to work. But I do think, and we've talked about this before, we have to re envision what healthcare does, what core
hmm
services people provide. But I think this shift towards testing out pay out of pocket models or asking the charitable sector to provide healthcare or trying to use some sort of nonprofit structure. We know that model doesn't work like pre
hmm
1947 before publicly funded healthcare came into Saskatchewan. We knew
yeah,
that was the infrastructure, right? I'm not saying that we can't introduce those parts in places that are not core services or introduce that into places where it's well integrated within core services. But this whole idea that you can just turn off the public system and turn on those other things to provide that infrastructure, it's pretty clear that doesn't work.
yeah, no, for sure. And I think what we're talking about is how do we align everything to the outcomes we want? And I think that's why what's interesting to me in BC is I think so much of what the problem of our system is it's not intentionally designed, right? It's a system that sort of started in the 60s and has limped its way along with permeations on themes, but it's been not intentional. What's the outcome we want, and how do we change what we're doing to align the incentive to that outcome, right? And that it's exactly this issue, right? What are the problems? The problems are administrative burden, complexity of patients, people needing more time. And how do we solve for that? We don't solve for that with high volume fee for service medicine. We solve for that by saying, okay, to provide that kind of care as a doctor, you need a package that allows you to do that. And they redesigned the payment to align with that goal of getting patients attached, having people being willing to take on complexity, longitudinal care, and actually treat it as a package of services rather than siloing out these individual interactions. And I think that's why it's worked because it's intentionally designed to line up with what we're actually trying to do. And I think that's missing in so much of these things. And I agree with you. I think when we just flip between random ideas to try to solve a problem rather than stepping back and going, okay, how do we intentionally design a system for the outcomes we want? I don't think we're going to get very far. And I think that's what we have so much of a history of, right? Is these pop up solutions to what is really complex problems. And I think we know that doesn't really tend to work very well. And you get all these increasing silos. So it's nice to see something that actually had the intended outcome. But I think the problem is it's just not enough, fast enough.
Mhm.
And the bigger problems of the system are still plaguing us. And I think these other things can be a distraction really from what is the core issue, which is that we have a healthcare system that's not intentionally designed.
Mhm. Yeah, and I think this time of distraction is especially dangerous because as you build healthcare systems, it's a very long tail to get them to grow and entrench in a way that is actually impactful. Healthy
Mhm.
work environments, people
Yeah.
being able to get access for the things that they need, parsing out when you ask a patient to travel, when it's unreasonable for them to travel. These things take a long time to form. There's lots of moving pieces, lots of folks that you can't just use a hierarchical structure to say, this is what the rules are. We're just going to do it this way. But in order to have those systems slide into the downward spiral, I think we're seeing in a lot of places across the country, it only takes a few really bad decisions. And
Yeah.
so maybe what I'd suggest is let's move from the eastern part of the country. We'll go to the west and then we'll look up to the north. And we both obviously consume a lot of healthcare information looking at the Maritime provinces. A little bit after your time as CMA president during my year, there was the announcement of the regional licensure model in that province. I think early signs are that's been positive. People have been able to provide care across provincial borders, especially in those border towns. I think there's been positive feedback and uptake of that model. One of the maritime provinces that really stands out to me is Prince Edward Island announced their medical school. Nova Scotia has had a lot of positive engagement with healthcare providers. I do think that that area of the country is going to run into a bit of a bump. They're starting to have healthcare contract negotiations between different levels of healthcare workers. I know Nova Scotia, their union has notified that there's a chance that they might strike. So that might be a bump in the road as they figure out their way, but moving towards team-based care, sharing of information for free movement of people across their different borders, and then increased capacity as far as training, I think is a positive longer term story for the maritime provinces. But interspersed with that is going to be contract negotiations, obviously.
Yeah, no, absolutely. And I think it's really interesting, the Maritime, smaller jurisdiction, but they've been a leader in a lot of these areas. And I think the Atlantic license is a really great example of how they're showing that leadership of what we're trying to achieve nationally, right? So we moved from there into Quebec and Ontario. I think we're hearing a lot of concerns in the Quebec healthcare system. What's really interesting, I think, is the number of physicians in Quebec who have opted out of the public system and into private
Mhm.
healthcare exclusively. Quite unique to Quebec. The rest of the country, that's a really unusual thing, actually. There's pockets of people doing that, very small numbers, but in Quebec, that number is growing. So I think that's going to be interesting in terms of what that means. And I think at the same time, we've got a government there that's treating people a bit with that stick approach, where to sort of
Mhm.
tell you what to do rather than trying to work collaboratively to solve problems. And in general, I don't think we solve for complexity very much when we get into those sort of warring type relationships. I think it's much better when people are trying to solve problems together because inherently, I don't think most of us react to the stick so much. So I'll be interested to see what happens there. In Ontario, there's so much concern about the aging population, seniors, which is really important. But sometimes lost in that dialogue is what's the impact for children. And what we know is our healthcare system has fallen way behind in terms of meeting the needs of children. The other thing we know is most chronic diseases start in the child age group and not meeting children's needs in terms of their development, mental health, delayed treatment for their medical conditions, which just costs more money later. And for some children can change the whole trajectory of their life in a negative way. Some of the conversations I think we need to be having is how do we get a healthcare system that works from when you're born until when you die and support children right from the beginning through, aging really starts when you're born, right? Right through
Mhm.
that critical period of development to optimal health as adults, people that can be really healthy, contribute to our great country, and then age well, healthy at home with dignity, which is really what people want. So, can we think of this as a continuum more than these silos, which is what we tend to do now?
Part of the news coming out of Quebec too that is a bit concerning is around the French requirements for folks
Hmm.
who are providing care. As we both know, like patients are not homogeneous across a jurisdiction. There's obviously the importance of ensuring that francophone patients have access to care in the French language and ensuring that English patients or English predominantly patients have the opportunity to access care in their language of origin, or if you're from out of country, it would make sense if you have a large consolidation of East Asian patients or Ukrainian patients or whomever. You should be able to receive care in the language that you predominantly speak. That would be an ideal healthcare system. And I think part of those language rules are pretty concerning. And then also the raising of tuition rates in French schools have impacted colleges of medicine down there to the point that they've had to pull back some programming. In Ontario, there's obviously a lot of activity around alternative sites for surgery. We've talked about
Mhm.
this in previous episodes. Obviously, we have to increase surgical capacity, make sure that surgeons who are not able to access surgical time are able to access surgical time. Like, you've obviously been trained, but you can't go into a place where you can work with a team to actually do the work that you've been trained to do. But lots of talk about privatization and outsourcing to these non-hospital based surgical facilities, just a way to change the conversation from calling it privatization to something different. Do you have any thoughts about that?
Yeah, I think again, it's interesting, right? Because I think it's complex. I think there's lots of
Mhm,
things to think about. We talk a lot about how things in the hospital or utilization isn't always optimized. We've talked a lot about nurses, the lack of nurses in terms of being able to provide all these services, the rising utilization of agency nursing, which has been extremely expensive and I think really ran up the budget of many hospitals. And then that concern that you're shifting the health workforce from one place to another when it's a limited resource. So is there that risk if you're doing an outside hospital surgical facility? Is it shifting resources there?
mhm,
And what are the outcomes and what's the value? I think the reality is we really need all these things to be happening simultaneously, right? We need to be optimizing our hospital utilization. I don't think it's necessarily bad if some surgeries are happening outside of the hospital, but it needs to make sense, right? If we have
mhm,
extractive forces that are taking dollars to generate profit that could be going towards patient care, that's concerning. If we have patients being upsold things they don't need in these settings, that's concerning. If we have people being kept in longer or hospitalized in these sort of pseudo private hospitals longer than they need to be just because that's how they can make a profit, like those are the concerning things, right? If we have the right mix of things where we're optimizing our hospitals where the sickest people need to be, and there's publicly available services outside of the hospital that allow us to get more people surgery and allow our surgeons to optimize their time in a way that's not extracting dollars from the healthcare system. I think that can be okay. But I think the problem we have right now, again, it's around governance, around planning. None of these things are really clear at what's actually happening. So I think it is worthwhile being worried about that and wondering what mean if it's either on a broader scale. I don't think one thing is inherently good or bad. I think it's all about how it's executed. And I think there's probably things to learn across the spectrum, but I do think sometimes that lens we have of tending to focus on the negative or how to prevent things versus how do we encourage things might be the wrong perspective.
mhm. Yeah, and then you move into Manitoba and Saskatchewan. I think that Manitoba, interestingly, is going through a lot of the same challenges as everyone else, but this is where sentiment and political leadership, I think, is really communicating. I sit and talk with folks who are working in Manitoba. They're struggling with the exact same things as the rest of us across the country, but they seem to have a much more hopeful uh, attitude toward what's actually going to happen. They feel like they're listening to the government. They feel like the government is trying to shepherd them through a really difficult time and that things will hopefully get better. And then in Saskatchewan, I think you're definitely hearing some frustration coming out of places like Saskatoon or Regina
Mhm.
a little bit more. And you are hearing about hospital closures in both those prairie provinces a little bit more in the news recently.
Yeah, no, I think you're right. And then you look at what's happening in Alberta,
Mhm,
and I think that's a real cautionary tale, right? I often reflect on how so much of the time we're looking and hoping that governments are going to solve the problems in healthcare. And I've talked about this before, the challenge of the election cycle, the length of time that people are in power versus sort of the complexity of these big systems that need movement. And I think what's happening in Alberta is a bit of a cautionary tale about how political agendas can really steer us away from the broader things we're trying to achieve in the healthcare system. There we have a government that's really dismantling years of progress in terms of an integrated, comprehensive healthcare system and now taking it apart little by little, really, I think for political ends, not really clear that what they're trying to do is going to be better in terms of healthcare service delivery. And I think these recent announcements about this idea of moving what they're calling underperforming hospitals into faith-based Health Organization, and the Premier even used the term wanting to instill fear in people. I think a concerning direction. And I worry about that, and I think that is the broad challenge when these big, important, complex systems that, as you said, are very easy to ruin quickly, takes a long time to build back, are at the whim of what politicians do. And I worry about what's happening in Alberta. I think they were so ahead of the curve in the country in so many ways, information systems, really like coordinating care, sharing patient information, and for a long time provided one of the best environments for physicians. So it had really excellent recruitment and retention. And now that's all changing. And I worry about what that's going to mean for that province. I think it does make us ask questions around healthcare governance and how we can work with politicians, but also be inoculated against the potential just pivots that happen when you have a government that comes in and has a completely different political agenda and wants to use the healthcare system as a way of pursuing that. I think I would call Alberta, as I said before, a bit of a cautionary tale of how politics and healthcare can really start, I think, going in the wrong direction.
Hmm. Yeah, and like you, I always pay a little bit more attention to the place where I'm currently working as far as how the healthcare system is going. And I I think what I read between the lines for the government is that there's an ongoing frustration that they had a difficulty impacting the decision making within Alberta Health Services, and that's one of the reasons for reorganizing it. But I think that's part of the the stick that you pick up. You can't pick up a stick just on one side. You got to pick up both sides, right? And I think when you have systems that are well integrated, to a great degree, you do lose some decision making power because you've now distributed that decision making power across the institution. And yes, things do take longer to sometimes change. You're obviously trying to bring together multiple different types of points of view into this shared vision of what the system can do. But I think in the frustration over not being able to influence some of those decisions, it's now gone 180 to the other way. And I think just like you said, and we've been talking about that, it's very easy to dismantle a system. It's very hard to put it back together. And I think especially for folks who haven't been through cycles of failure inside the healthcare system, it's easy to think I would do this in like a private business. I would do this in another sector, and it worked. Healthcare is fundamentally different. You're dealing with people's lives, the highest stakes that you could imagine. You have multiple touch points across a patient's journey that involve a bunch of people that you can't really tell what to do, and that the amount of government oversight and investment you need to watch the decisions that were being made in real time and then trying to adjust them. You just can't do that. Even in a clinic day like yourselves, you're seeing scores of patients over your day. How is a government bureaucrat going to stand there and look at every one of the decisions you made and then try and adjust it in alignment with something that would be lower cost savings or some other type of outcome that the government wants? And you really do have to trust people in these complex systems to do their job.
Yes,
And
I agree.
yeah,
Yeah.
government sitting down and making rules that are clear and then creating opportunities for people to coordinate with each other, no matter how the system is set up, is something that takes a really long time to get to. And Alberta Health Services took more than 10 years to get to
Yeah.
the point where it is right now. And it'll be dismantled, I think, in less than a year. And what
Yeah.
comes next, if you listen to people working in the system, and I think patients trying to access care, it's not a whole lot of good news. But
And it's also
yeah.
millions of dollars, right, being
Mhm.
spent to dismantle the system. Like, how is that improving care for people? And that really, yeah, that worries me. I think what the long-term implications are going to be. And again, I think when you're working in an environment like we are right now, where really, in terms of market demands, right, there is endless demand for health professionals, very limited supply, very easy for people to exit the system they're in and move somewhere else because we literally could get a job as a doctor or a nurse pretty much anywhere in the country right now that you want to. There's so much demand. So it's not like you can count on that to keep people where they are if they're not happy. So I think it's a big risk, I think, when you're really threatening people's sense of comfort in the system they're working in, when you're threatening their sense of being able to do their job well. I know there's all sorts of standing issues that have not been resolved in Alberta between the Alberta Medical Association and government, and there just don't seem to be able to be making any forward progress. And I think that's worrisome, right? Because I think we know that the vast majority of physicians are deeply care about the public system working well for their patients, and that's their primary driver of what they want to see. They want to be at the table and they want to be solving problems. But that's challenging when you're not really being invited to the table or listened to, and you're not seeing any forward momentum on solving these problems. If anything, you feel like things are moving backwards. So I think, yeah, Alberta is definitely going to be a province to watch here over the next month, and I think that we're going to see a lot more concern coming out of that province for sure.
Mhm. Yeah, and I think if we move over to BC now, like
Hmm.
they are experiencing a lot of the same sort of cancer care access problems that Alberta is experiencing, but it's interesting that the sentiment is very different. And the path towards what comes next, folks in those areas recognize that it's a problem, but they're getting more entrenched. They want to help deal with the problem versus looking at different options. And I think that the tales of the healthcare system across the lower Canada provinces really illustrates that for folks who are experienced in the system, we want to stay where we are, fixing things, right? Like we're not chasing after that shiny new object. We've been around for long enough that we've gotten used to the people that we're at. We feel like we're contributing to our communities and the patients that we serve. It takes a lot of time and effort to pick up and move to a different part of the country. And so I think for folks who are in the mid part of their career, which personally I think is one of the most productive and impactful parts of a health professional's career, whether they're a doctor or a nurse or pharmacist or whomever, what you're really balancing is whether or not things are so bad that people are getting pushed out
Hmm.
versus having those people compete to, oh, I can make 10% more here, or even 20 or 30% more in a different province. And I think that that's something that's illustrated really well between BC and Alberta. Like when BC moved towards this new payment model, what it was communicating to people is we value you. We
Yes.
we hear that you want a different type of structure. We're going to try out this other thing. We don't have all the other parts of the system fixed yet, but we're trying. And I think what folks in Alberta are hearing with some of the changes, whether it's intended or not, is that we're going to do what we want and you're just going to have to figure it out. And I've heard from a lot of colleagues that they feel like they're almost being dared to move
Hmm.
away, which I think is it's a dangerous way to run any sort of system.
Oh, I agree. I also am a strong believer that I don't think you ever get your best out of people through those types of relationships, right? I think people perform their best when they feel respected. People give more when they feel like they have a voice and they're part of something. And when you give people that responsibility, I think people rise to that challenge. I think when you push people down and them feel like you're at odds with each other, I think that's when people start doing the bare minimum, right? And
Mhm.
that's not the type of culture that we want to be cultivating at all. Speaking of BC, I agree. I think it's been great to see some of those positive things happening in primary care, office-based primary care. Of course, it's again, like we talked about at the beginning, one of the challenges when you make changes in a system with limited capacity is a win in one place can cause challenges elsewhere, right? So what they've definitely seeing the pressure on hospitals now that lots of family doctors who had been working more in hospitals have shifted back to office-based care, which is great. But now there's a lot more demand that's not being met in the hospital. Again, what we've got is we're shifting a limited group of people in different places. And even though this is a win here, it means an unintended consequence over here. The other big challenge in BC, I think, is just capacity, right? Seeing
Mhm.
that with cancer. We've been seeing that with neonatal care very recently. There was not a single neonatal ICU bed available in the province of BC, not one. So I think as the population grows, and this is again, I think one of Canada's challenges is our population's growing and increasing through immigration, which is incredible for so many parts of our society. Have we ensured that the things that people need to thrive are in place? Can people be housed? School, people access healthcare. These fundamental services are just not designed to keep up with the population growth. And I think that's why we're just seeing overwhelm of all aspects of the system that's having some really negative impact in terms of people's care. And that's, I think, really concerning. And again, I think it comes back to some of the themes we've touched on before, which is just a lack of an overarching plan and increasing capacity in the system to keep up with population growth, aging population, increasing complexity in children, more people surviving with different challenges, and just more needs in general in the healthcare system. And we haven't planned for that. And now I think we're seeing that with these systems that are constantly overran and having to ship people away for care. And that's expensive, very stressful, and arguably not very sustainable rather than
Mhm.
investing those resources in growing a better system. So I think BC's got some wins, but some cautionary tales there as well. It'll be interesting to see what happens with the upcoming election.
Yeah, a shift in political parties can obviously change a system and turn a healthcare system on its head. So something to watch for sure. Now moving north, lots of news going on in the Yukon, Northwest Territories, and Nunavut, not the least which being creation of a new healthcare region in an area where you work.
Mhm.
Maybe you can comment on some of the stuff going on in the north.
Yeah, so the Yukon does not have a health authority. It's the only place in Canada without that. So there's been legislation that's been worked on over the last year and a half in the Yukon, been passed in the legislature that really creates the legislative possibility of creating a health authority. So the actual work on creating the health authority itself hasn't started, but this is really enabling legislation to set the ground around doing that. I think what's really unique about it is the government worked very closely with First Nations leadership in the Yukon to develop this enabling legislation. So that's something that I think is really positive and interesting to see what that's going to look like in terms of how that healthcare system is both developed and then governed, and some opportunities there to maybe have something that looks different than we've seen before. So I think that part's interesting, but I think there's still a lot of work to do. There's still lots of ongoing challenges. The hospital is much too small. The territory is growing substantially in the last 10 years. The population has increased by over 15%. The size of the hospital's gotten smaller over the years, not bigger. It's constantly over capacity. It's really being pressures really felt in the operating room that need to be modernized, and that has not happened. So we're seeing real challenges there. Um, Lack of access to primary care, ongoing challenge, and the Yukon Medical Association did a survey that showed in the next 5 to 10 years, almost 30 to 40% of physicians are thinking about closing their office-based practice. So leaving even potentially more Yukoners orphaned. So again, I think it's that need to go, okay, what are the problems we're trying to solve and how do we step out from how we've usually done things to really address these problems in a way that creates something different and more sustainable? Because quite clear that more of the old ways of doing things are probably not working. There's been some definite, I think, positive light, like the government recognizing the need to integrate allied health professionals into doctors' offices, and there's been some opportunities for clinics to do that type of work together with the government, which I think is really great. Because again, it's that how do we get integrated care? How do we make sure the right people are doing the right things? And they're creating some opportunities there, which is fantastic. So I think it's some stressors, some positives, but lots of big problems to be solved in the Yukon, but a really fantastic group of people, I think, wanting to work towards that. So I think, again, the next 12 to 24 months are going to be really interesting just to see how can we move the dial on some of these bigger issues.
And I think as you look at the problems that you just described in the Yukon, moved to the Northwest Territories and Nunavut, very similar challenges. One thing that I've been hearing and thinking lots about is just the whole role of medical transportation in shifting people from places where they can't get care to places that they can. We talk about these different systems down south, but to patients, it's all one integrated system or supposed to be one integrated system. And when someone gets sick in Northwest Territories, one of the first places they come is down south to Alberta. And if within the provinces we're seeing folks being transferred from areas of kind of low capacity, so rural areas in particular, northern areas, remote areas, to the more centralized locations like our big cities, and they're having a very tough time getting capacity to transfer people into those places. I have to imagine that medical transportation in the coming months is likely going to be an even bigger issue because if you have somebody who's in Nunavut or Northwest Territories or in the Yukon who needs to be urgently transferred out, and folks who are there don't even have enough room to take care of people that they have in the city, where do these folks go?
Oh, I agree. And we absolutely come up against that. And it is concerning, right? Because again, the other provinces have taken patients from the north and cared for them. But I agree with you, as you see system constraint and resource constraint, suddenly people are going, maybe we actually can't do that anymore. But then the question obviously is left is then what happens to these folks that need
Mhm,
this other
mhm.
care? So yeah, I agree. I think that's really concerning. It's obviously a huge pressure and burden on families and the patients when they have to go with a huge financial cost. And I think that's one of those hidden things again in healthcare that people talk a lot about. We're fortunate in the Yukon, we have quite a good medical travel program, but lots of places don't have that. So all
Mhm.
of a sudden, if you've got to go, this is on your dime and the cost would be absolutely great people. And that's again, when we think about universal healthcare and what's covered, I think people don't always realize that things like medical travel, even though it's absolutely necessary, isn't necessarily a covered expense for people. So that can be really challenging, especially when people are facing big things. Every time I diagnose a child with cancer, in the Yukon and they're getting on that Medivac plane, usually it, of course, comes up very rapidly. Often the child's quite sick. And I'm thinking to myself, you're not coming home for 12 months. Like that's what this family's facing. In a matter of an hour, you've brought your child in, boom, you're told your child has cancer. You're getting ready to load on a Medivac and you may not see your house again for 12 months. These are
Yeah.
the crazy things that happen to people. And again, I think it hasn't happened to you. It's maybe not something that you think about, but there is that burden. And then agree, what's it going to look like as things tighten up in these provinces? Where are people going to go? And I think it comes back to that theme around access, capacity, health, workforce planning. How do we keep meeting the needs of more and more people with complex problems and a growing population?
Mhm. So lots to talk about in the upcoming episodes. I think we touched on some early things that we'll be watching for is further collapse of healthcare systems, but there is good news out there. There will have to be good news if we're going to sustain the healthcare system and build into something more resilient. We're also going to be looking at some special guests that will be joining us on the pod in future episodes. So you definitely look forward to that. But I think at this point, it's probably a good time to end episode 4 of the Health Signals podcast. And as always, Catherine, nice to catch up and looking forward to the next time we meet.
Yeah, great to see you again, Alika. And I'm also looking forward to diving into this next few months and unpacking these things for our listeners.